afternoon, teacher. My topic lowers versus traditional treatment result for neonatal hypoglycemia. My University Católica Santiago de Guayaquil. My name is Yadira Cando, course 8, Mother English Technical. Definition: hypoglycemia can lead to the morbidity under neurological. There is no current indicator of the values that should be considered as the sub-limit, and it remains one of the most controversial issues in many segments of the newborn. Continue my video.
Hello, in this video we're going to talk about neonatal infections, the unwell child. Signs and symptoms of an unwell or ill neonate include lethargy, stiff limbs, cyanosis, grunting, severe chest indrawing, capillary refill more than 3 seconds, and this is checked on the sternum, an increased respiratory rate greater than 60, high temperature or low temperature, again stiff limbs, and movement only when stimulated. The first neonatal infection or condition we will look at is sepsis caused by bacteria. And sepsis is essentially the body's response to a systemic infection. It is common and commonly overwhelming with high mortality. The signs may be minimal, but usually the signs and symptoms are those that we discussed in the start of the video. Sepsis can be divided into early onset or late onset. Early neonatal sepsis means that this is occurring less than 48 hours after delivery. Late onset is the neonate is already older than 48 hours. Sepsis is often confused with bacteremia. Now, bacteremia is defined as the presence of bacteria in the blood, where sepsis is the response to the bacteria, which includes vasodilation, causing hypertension, tachycardia to compensate and to maintain cardiac output. Sepsis is caused, usually secondary, to a bacterial infection somewhere in the body. So the primary infection occurs somewhere in the body, such as the lungs, you get pneumonia, skin, cellulitis, urinary tract infection from pyelonephritis, gastroenteritis, or from the bones, osteomyelitis. All these primary infections can lead to dissemination of that bacteria, causing sepsis.
Application is nursing. Check the temperature every 15 at 13 minutes. Keep the newborn thermoregulatory stable by venous. Administers glucose according to the medical indication. Continue my video.
Hello friends, today's topic is neonatal hypoglycemia. In this we will study the role of feeding during first hour, pre-warming, why we'll do pre-warming of heel before taking the sample for hypoglycemia, and best method for glucose estimation, and which babies are at risk of hypoglycemia, and clinical features of hypoglycemia and management we will discuss on the second part of the video. What is neonatal hypoglycemia? Neonatal hypoglycemia के लिए पहले हमें नॉर्मल मेटाबॉलिज्म देखना पड़ेगा. What will happen? During the intrauterine life, the glucose is transferred by the placenta to the fetus, and during the last trimester, excess glucose is stored in the glycogen. One thing is that, and during the intrauterine life, insulin is secreted by the mother and transferred to the placenta. And after the birth of the baby, the insulin is secreted by the fetus themselves. So, when the baby born, the glucose supply is cut off by the placenta. The glucose supply is cut off, but the baby can secrete insulin by himself, so the baby can go into the hypoglycemia during the first hour of life. So we have to give the feed to prevent hypoglycemia, because insulin is secreted by the fetus themselves, but glucose is suddenly cut off. So that causes hypoglycemia to the fetus if we don't give feed during the first hour. One is role of feeding. Second is why we'll do pre-warming of heel before taking sample for hypoglycemia. And what is the normal level of hypoglycemia for children? Less than 40 mg per deciliter is considered as hypoglycemia in children. And if we know that the heel, the blood supply is poor, so there the glucose concentration is also poor, so it will lead to false results if we take the blood from the heel. So we do pre-warming so that the increase the vasodilation and increase the blood supply, so that glucose range is in the normal level. If baby is hypoglycemic, then only we can find the glucose level low, not in the normal baby. And what is the best method for glucose estimation is the glucose oxidase method. Now, which babies are at risk of hypoglycemia? दिस विल बी ये तब समझ आएगा जो हमने पहले वाला मैकेनिज्म पढ़ा है कि ग्लूकोज की क्या शुरू में ग्लूकोज बनता है बेबी में, मतलब प्लेसेंटा से ट्रांसफ़र होता है और इंसुलिन प्लेसेंटा से जाता है, लेकिन आफ्टर द बर्थ ऑफ द बेबी द ग्लूकोज इज डाउन बिकॉज सप्लाई इज कट ऑफ एंड बट इंसुलिन कैन बी सिक्रेटेड. उस पॉइंट से समझ में आएगा. सो विच बेबीज आर एट रिस्क ऑफ हाइपोग्लाइसीमिया? फर्स्ट देयर इज प्रीटर्म. Why preterm? Because in this the glycogen stores are less, because they are lacking the time during which the glycogen are stored in the liver, so they are risk of hypoglycemia.
Pros and the cons. Risk factor. Being born smooth and gestation against small or discordant twins. Lager for gestation against child with a diabetes, mother of the with a DMG, RN with hepatomegalia. Continue my video.
Remember to subscribe and don't forget to hit the bell icon to never miss an update from First Cry Parenting.
Sweat applied in the Ecuador. In the Ecuador, there are many premature newborns, small or larger for gestation. Again, or those born to the mother with diabetes are screening for hypoglycemia with the aim of preventing brain injury. However, there is no consensus on the treatment threshold, that is the sub, but also avoid our treatment. Continue my video.
Welcome to NICU Essentials lecture series. Today, we will be talking about neonatal hypoglycemia, a common condition in both the NICU and newborn nursery. In today's lecture, we will be going over glucose physiology and homeostasis, the transitional hypoglycemia that occurs in newborns, differential diagnosis, risk factors, criteria, diagnostic evaluation, and management. In utero, glucose is transferred from the mother to the fetus across the placenta via facilitated diffusion. It should be noted that maternal insulin does not cross the placenta. After birth, the continuous supply of glucose provided by the mother ceases, and neonates need to regulate their own insulin concentrations. This is why it may be normal to see lower blood glucose values in the first 24 to 48 hours after birth. The newborn brain is dependent on a constant supply of glucose. The healthy newborn requires a higher GIR compared to adults due to proportionally larger brain to body mass ratio. In a state of prolonged starvation, the liver plays an important role in homeostasis by producing ketone bodies, which the brain may use. However, liver glycogen stores are rapidly depleted after birth. This diagram illustrates the complex pathway that is involved in glucose homeostasis. ATP production is maintained by glycolysis, glycogenolysis, and amino acids. It can be expected for newborn glucose concentrations to decline within the first 2 to 3 hours after birth. Transitional hypoglycemia describes infants who are inefficient at producing ketones, have lower amounts of fatty acid to utilize, such as small for gestational age infants, hyperinsulinemic, such as infants of diabetic mothers, large for gestational age infants or post-dates infants, and infants who inappropriately retain liver glycogen stores, such as in metabolic diseases. Neonatal hypoglycemia occurs in up to 10% of healthy newborns. The AAP definition defines hypoglycemia within the first 4 hours of life as less than 40. Hypoglycemia between the first 4 to 24 hours of life is defined by a blood glucose less than 45. This reflects the decline in serum glucose that normally occurs after the first 2 to 3 hours after birth. In contrast, the Pediatric Endocrine Society defines hypoglycemia within the first 48 hours as a blood glucose less than 50 and hypoglycemia as less than 60 beyond 48 hours. We will be focusing on the AAP definition in this lecture, but it is important to realize that generally, after 48 hours after birth, blood glucoses should be greater than 60, as defined by the Pediatric Endocrine Society. Prematurity is a large risk factor for having hypoglycemia. Low hepatic glycogen stores, inadequate muscle stores, and inadequate lipid stores are all reasons why hypoglycemia frequently occurs in premature infants. Infants of diabetic mothers who have hyperinsulinism have inappropriate secretion of insulin, which puts them at risk as well. Small for gestational age infants have inadequate glycogen stores and substrates for gluconeogenesis, similar to premature infants. Finally, inborn errors of metabolism, sepsis, pituitary disorders, cortisol, and growth hormone deficiency should be considered in cases of refractory hypoglycemia. It's old and has a confirmed hypoglycemia that is less than 25, the infant should be given IV dextrose. If the glucose is between 25 to 40, the infant may feed, and the glucose should be reassessed 30 minutes later. If an infant is between 4 to 24 hours of life and the glucose is less than 35, the infant should be given IV dextrose. If the glucose is between 35 to 45, again, the infant may refeed and be reassessed in 30 minutes. It is important to note that if at any time any infant is symptomatic, then the infant should be immediately treated with IV dextrose regardless of glucose value. The following algorithm reviews the hypoglycemia treatment protocol as described. This algorithm is also included in your resident code cards for easy reference.
Conclusion. Eat a healthy newborn with asymptomatic moderated hypoglycemia, a lower glucose treatment result, 36 for deciliter, what not foreign to traditional result, 47 deciliter, with a regard to psychomotor development at 18th month. Continue. Thank you for you for a prestation. Thank you.